Chaudhary to sort of debate on. Evidence-based medicine, should we adhere to that, and should evidence-based medicine be considered as a guideline or a quality indicator by itself? You know, the problem is that when a small country like Bhutan, which is me, is going to challenge somebody like USA, which is Professor Dhruv Chaudhary, I have to look at what my opponents are basically in terms of their strengths. So I'm trying to make up a case for a pro out here, and let's see how we can succeed. So what I did, I went onto the Rohtak website of Professor Dhruv Chaudhary and looked at his CV, which is there on the website. So first is guideline. Okay, second is another guideline. I can go 3-4 pages like that. What is my success to glory? I've written one guideline on brain dead patients, not even alive patients. Forget about alive patient, on brain dead patient. But sir, I'm still learning. I'm still sort of trying to go across. But it's very important now that we need to have a guideline for dead patients as well, because what happened in Max Hospital, Delhi, we need to have guidelines how to declare patients dead and how to sort of look after the dead patients as well. Anyways, let's come up to the topic. So, should evidence-based medicine and guidelines be a quality indicator by itself? The problem is not in the challenge that evidence-based medicine is there to be recognized or not. It is already recognized. People understand that there is evidence in medicine and we need to follow that. It is just like if I start walking on a footpath versus a road, I know that I am going to be much safer on a footpath because that's what I have been taught as a guideline from my childhood by my parents. But if I start walking on the road, the chances of getting hit are very, very high. So if I start doing things which are not evidence-based, the chances that I am going to cause more harm to the patient is very much there. So I need to start following up things. The problem is what? The problem is that we need to have hospitals where there is a culture to sort of follow the evidence-based medicine and then decide that that would be my quality indicator itself. If I am not following evidence-based medicine, rest of my quality indicators really don't matter. Because if I don't look at the quality, then what am I going to look at the quality indicator for, right? So there is a problem with the physicians and the intensivist attitude of not being able to change themselves. Fortunately, a lot of them have now started understanding it and going across to the change. So what does the quality indicator do? Quality indicator essentially helps us in differentiating what is a good and a bad outcome and a process. It is probably often a surrogate marker. It is not the only marker which sort of tells you what is it. And it is usually based on the best available literature, and if the best available literature is not there, then it is usually based on the consensus or some sort of an expert opinion. So that's what forms a quality indicator. So when we talk about a quality indicator, these are the things which you look for. So how can evidence-based medicine be sort of ignored into that? Theoretically, it is okay. You may have quality indicators present there, but there still are problems in quality indicators. Okay. In theory, you may have a therapy standardized and individualized for a patient, for a therapy for a patient. But in practical, is the clinical routine so organized that the errors are not going to happen? Does the patient normally receive what we would like to believe that they are receiving and what we are trying to achieve? These questions cannot be answered unless you are rigorously following quality and you are rigorously basically keeping that as an indicator. There's something called as a RUMB, a Rumba rule for a quality indicator. This was very interesting. So it sort of tells you what a quality indicator can be, right? So it should be relevant to the problem. So if I am practicing medicine and if I am not practicing quality and I am not taking that evidence-based medicine as my quality indicator itself, then I am not really relevant to my medical problem because I am sort of deviating to that through that. It should be understandable, it should be measurable, it should be changing through the behavioral things, and it should be achievable. Okay. So let's look at the definition of evidence-based medicine. It is the practice of evidence-based medicine includes the judicious integration of current best scientific literature, clinical experience, and patient's understanding and the values. It has got 3 components in it. What are the 3 components? The 3 components are clinical training and experience. You have a patient preferences and values, and you have a judicious integration of science. And if I don't use combination of these 3, I am doing a disservice to my patients. Okay. So again, comes back to the point of evidence. Now I'm talking about evidence-based medicine. We have a talk to follow by Professor Ram on evidence-based medicine. I'm just waiting how he's going to sort of dismantle everything which I have told right now, or maybe support it. I don't know. Let's see. Wait to hear from him. What is a guideline? Guideline basically is a framework of what evidence you have available. Okay, so it's a systematically developed statement to assist practitioners and patients discussions about appropriate healthcare for specific clinical environments and circumstances. And where do they come from? We have a plethora of literature which comes across. More than 10,000 studies come across. You have more than 10,000, 7,000 guidelines which are available right now. There are almost 4,500 index, non-index periodicals which come across from the world. And when we do a study, we look at all of these. And if you are going to, what we think of, that if there is knowledge available, you use that knowledge, and you use that knowledge to the benefit of the patients. And if you're not able to use that, then you're not doing a real service. Is evidence-based medicine the whole truth? So what evidence-based medicine is, that it defines the likelihood of something happening. It basically is the evidence. Evidence never tells you what to do, but it sort of gives you an option. It gives you what are the best options to make your decisions. It is not going to make a decision for you. So you don't sort of think that evidence-based medicine, if I follow that as a quality indicator, every time I will be able to make up a decision just based on the quality, because you will have to individualize it. So there are some shortcomings in that. You need to still have your clinical acumen going on. But you need to understand that that evidence will basically help you in giving you different options to sort of understand what is there. And what do the guidelines do? Guidelines, importantly, is a good leveler. Why are surviving sepsis guidelines being followed all across the world? To whatever extent they are followed. They may not be followed to the true 100%, but they sort of bring across a good leveler. They take away the operator variability. They take away the individualization. We are able to compare between the two units, so we are able to compare between the two patients, so we are able to compare between the outcomes. And it sort of helps us to, compare, look at apple to apple, not an apple to an orange. So I think guidelines are important, and if you are going to look at evidence, you are going to basically follow the guidelines as well, so that you know that you are doing the right to the patient. Now, these are some of the examples of where real life doctors did not follow guidelines, and see what happens. From senile cataract, where almost 80% of the times the care was given as per the guidelines, coming down to what is important for us in ICU, which is hypertension, diabetes mellitus, and alcohol dependence, hip fracture. You can see almost 20% of the times, just 20% of the times, people are following what is being prescribed as a guideline. So we are really not doing what we should be doing, and non-adherence to that has led to number of publications and studies where they have shown that the adherence to guidelines is really poor. And are we in this day and age really justified in doing all of this? Then comes up the question that if I am going to basically adhere to evidence-based medicine, what is the grade of that medicine? What is the grade of that recommendation? It's very difficult to sort of ignore that, because you need to look at the strength, which is the desirable as well as the undesirable effect of a recommendation. And based on the strength of the recommendation, you would have then a recommendation which might come up as a strong or a weak evidence or a consensus statement only. And then you need to take up a decision. So you have options being given to you, that this is the evidence which is available right now, and I'm going to take that up as a quality indicator for myself. Now, the question asked would be, why are we talking about this? This seems to be a new phenomenon in the last 20 years, when the periodicals are available for us on the internet, when everybody is able to have the information at their home. We are talking about evidence-based medicine. It never existed before. Not true. Okay, now this is just one of the examples which I found out. Way back in the 1700s and around 300 years before that, bloodletting, asking the patient, letting the patients bleed out, was a standard practice. And one of the French physicians, he sort of analyzed that with bloodletting sort of help us in treatment of acute pneumonia. And he examined around 70 patients, odd patients, and found out that it was not the best option to be really done. So this was late in 1700s, and now we've come up to a point where we don't even think that as a therapy. So evidence has evolved in the last 300 years, and the last 20 years has evolved into a larger way. And this is where the gap is. There is a lot of evidence which is peaking up, but what we are actually following, the gap keeps on increasing and narrowing and widening up. This is a decision-making process. If you look at the decision-making process, there is a staircase, and that staircase basically looks at your time for making a decision to a time to take an action. And if you don't follow evidence-based medicine, you are essentially missing out on these 4 or 5 steps. and then you're basically jumping straight to an action, and that is not really acceptable in today's day and age. You need to have an action which will be based on your decisions. Evidence-based medicine, if I follow, will also save money. I would know which evidence to interpret and which evidence to basically make it work. I would also save money from not doing unnecessary things. Fortis and Apollo, just like Suresh was saying, are being criticized right now. So it's very important for me that I should be able to justify every investigation which I do, or every procedure which I am requesting for. And I'll be able to allocate resources adequately. Now, when it comes to resources, it's an interesting finding again. This is a very, very interesting study. Pay for performance. So physicians were paid to adhere to guidelines and evidence-based medicine. The moment payment was associated with it, the compliance was very good. Okay, the payment was not associated with it, the compliance was not very good. So why are we sort of waiting for a monetary gain? Isn't it our natural the hypothesis or the thought process that the patient should be the first one who should benefit, and if we follow guidelines, this is what would happen. Medico-legally, number of cases, it was interesting reading through for this talk. I went on to some of the papers published about if the physician was adhering to guidelines, especially in US courts, what was the judgment which was given, and if it was not adhering to guidelines, what was the judgment which was given. Fortunately, even in US, they are sort of not so proactive when it comes to the judgment, that if you are even sort of straying away from the guidelines and doing a thing which is in the best interest of the patient, the judges are able to take up a reasonable and rational decision. Many of it is based on the expert opinion which is given by some other doctors as well. But they do take a notice that was evidence-based medicine followed or not. So it is being noticed now. So medico-legally also it is very important. So coming back to the question, last couple of slides, can evidence-based medicine be a quality indicator by itself? Adherence to evidence-based medicine be a quality indicator by itself? Well, when I talked about the qualities of a quality indicator, I should be able to measure it. So I don't have a numerator and a denominator for that. So at the best, it would be probably a sentinel quality indicator. A number of doctors who follow the guidelines in publication, and it probably could be a process and an outcome indicator. It probably is a very good, robust process indicator, and this is what the management and the medical admin guys are using against us. They are actually asking us to follow these guidelines and putting up processes. The JCI, the NABH basically look at these as the process outcomes and the process indicators and ask us to sort of follow that up. It is also a very important safety indicator. So if you follow evidence-based medicine, you are going to be in a much safer zone for the patients. For example, hand hygiene. Hand hygiene, we all know, has been a very, very simple way of preventing infection, but woefully poorly practiced in actual world. So IICCM has got more than 13-14 quality indicators for intensive care. All of them have been based on evidence and guidelines. If you don't follow evidence-based medicine, what is the point of having your morbidity, mortality, pneumothorax, central line infections, ventilatory associated pneumonia? None of that makes a difference. Last point, I don't think we can sustain in this day and age without actually having to adhere evidence-based medicine as a quality indicator. It is a great equalizer when you follow evidence and you follow guidelines. You would probably be happy to know that you may even be saved in medico-legal cases if at all there is a case and you are following the path of quality indicators. And by adopting principles of evidence-based medicine, it will be possible to maximize the benefits in a scientific way to your patients. Thank you very much. Dr. Professor Chaudhary, all yours.